Hello, good morning everybody. We are back again with the entertainment during the coffee break. So again, grab your coffee and listen to us. We have an eternal discussion, and this is EMR versus ESD in the colon. You know, I'm a little bit over 50, so I've been listening to these discussions for the last 15 years. And there are two groups with religious ardor which fight each other, despite there is zero evidence. So our hope today was we invited two experts, that you two ladies, Evelin Dekker and Roberta Maselli, you are maybe less fanatic towards those topics.
Okay.
So to start with very briefly, we don't have evidence, but in daily life, Roberta, when do you stand for ESD? So yep. ESD is green, blue, and EMR is white. When do you use ESD as opposed to EMR?
So talking about colorectal lesions, for sure in the rectal lesion, in all the rectal lesions. So now we have evidence now that there's a lot of uncovered cancer in that type of lesion. So for sure, for any type of rectal lesion. And the thing is that it can be different in the colon. So I think that there's a gray area where still there's a debate. But according to me, in the rectum, there's no debate.
Okay. So green says rectum belongs to ESD. Not so sure. Evelyn?
No, not so sure. I agree about the issue about uncovered, unseen cancers, so the covered cancers. However, we also know that if you relate location with size and morphology, you can at least estimate something. So I think after inspection really well of the lesion and you don't see any areas suspicious of invasive growth, I think the really just granular lesions without a dominant nodule, without being non-granular, without anything, I think it might still be justified to take it out piecemeal, especially if very large, because those procedures request a lot of time and effort for ESD to be performed, to be, for sure, as well in toto. So I think those lesions you can still justify to EMR. But I agree about the ones with the dominant nodule or the non-granular ones. I think in the rectum, I agree. There's good indications to do ESD. I also agree about the gray areas for higher up in the colon, because also the indications are for sure much less. The chance of being invasive is much less, and the skills for doing yep. EMR in the colon are just actually more difficult.
Okay, there's almost too much consensus, so let's look into this a little bit further. One issue I'm a strong non-believer, I must say, is endoscopic prediction. Because I think the majority of lesions is still benign, even if some of them look ugly. And we should take into account that high grade is not malignancy. So the Far East definitions of mucosal cancer don't apply here. So prediction of malignancy, what's the accuracy if you take all lesions with some suspicion, a nodule, some irregular areas, Roberta? What do you think is the accuracy? Is it much more than 50%?
I think so, yes, it's more than 50%, but at the same time, sometimes we have a lot of surprise, you know, that you see, you think that is benign, then it's not, and on the contrary, you think it's something more aggressive and you spend a lot of time and effort in removing that lesion and block with ESD, with something that is still difficult to learn and to teach, and then it's benign. So still we need something more. So I hope that in the near future we have also some tools maybe coming from all this new novelty coming. Maybe the artificial intelligence will enlighten us, giving some more details, because there's something we are still missing.
Yeah, I agree. I'm not so sure, though, whether AI in itself will be able to help us very soon, because as long as you don't see it on the outside, that's what AI does as well, right? I think, however, AI might combine the pit pattern or the JNet or whatever you use with size and morphology and location, so that, and it might by itself make an algorithm instead of us thinking of that, but experts probably will be the same. So I don't know if AI, it's going to be very challenging for AI as well, apart from this also from learning it, because the lesions are relatively scarce and they need a lot of data. There's another issue, though, and that's that we know now from a recent study published in gastroenterology on a meta-analysis on risk factors for lymph node metastasis, that even an SM3 lesion, so deeply submucosal invasive growth, without any other risk factors for lymph node metastasis, only has a very low chance of having lymph node metastasis. So if there's no lymph angioinvasion, if the lesion is resected properly, no tumor budding, no bad differentiation, risk is only 2-point-something%, so very low. So even then, deep submucosal invasion might be properly removed.
Okay, we now have two topics. One is, can we recognize? And the other one,
the consequences.
Do we overtreat?
Yeah.
Yep.
So the first one, just maybe going back for a second, is my opinion about AI, which is I think expected like God coming. But I think if you train it properly, and it's still not possible to do it, then it's not possible at all. Yeah, maybe the features of the surface don't correlate. But there's a lot of work to be done, isn't it?
Yeah, the thing is that I completely agree with Evelin that we are training the machine in doing the algorithm on behalf of us. So we are forcing the variables that have to be taken into account to judge that lesion. But maybe we are missing some variables that where they are, we don't know. So if we are very expert, we are doing the algorithm by ourselves, with our mind, with our connection. But maybe the AI will make the difference for small centers, no, that they are not so expert. So there are different fields of application.
Well, I'm not so sure about the holy expert and the rest of the... But Evelin, I love your study we had in GUT a few years ago, where you showed that out there, even well-trained endoscopists, you have this systematic program, and they were correct in cancer recognition because it was so rare in 39%. Yeah. So there is a lot of room for improvement.
Yeah, but then there's the question whether they will all be recognizable in the end, right?
Exactly.
Because I think part of them were just not seen well by anybody, but there will also definitely be part that's challenging also for experts.
Right, so maybe not even by AI, so the expectation is too high.
We don't know.
The other point, Evelin, you were touching on, and that's also very, very interesting, that these current holy rules of low risk, I think they're broken apart, aren't they? Can you tell us a little bit, because you have nice data from your study group?
Yeah, so we were very interested to understand whether deep submucosal invasive growth in itself is a risk factor, because it was always seen like anything beyond SM1 is too much, and you have to operate those people because they have lymph node metastasis. But actually, a large part of those patients also have other risk factors like tumor budding or bad differentiation of lymph angioinvasion. So there were other reasons, and I think we just have now shown by meta-analysis data that taking out those with just deeply invasive growth, there's a relatively large part that doesn't have any other risk factors and can still be treated endoscopically. And those are the ones you want ESD or maybe EID for, to make sure you have appropriate histopathology, because otherwise you won't be able to show.
Yeah, because in that case, the piecemeal is a problem.
It's a problem.
Still. Yeah. Even if not the depth of growth is not maybe so important, it's not the only factor affecting the outcomes in long term. Yeah. But the type of resection, it will.
Yeah.
Although, in all fairness, we have to say the outcome counts. Everybody says, if it's not en bloc, we can't say anything. But at the end, you have to look at recurrence and cancer rates, because that's the only hard outcome, not some histopathologic surrogate parameters. So,
and also, for example, I mean, it's also challenging to, if I really want to debate with you, when you have a large nodule in a granular lesion, probably if there's any invasive growth, it's going to be there.
Yep.
If you just resect that part en bloc and do the rest more quickly piecemeal.
I can't debate.
I mean, there is no data, but it might very well be possible to. That would be sufficient.
Okay. So Roberta, again, back to your strategy in the rectum. So you would accept you do 100 lesions and 30 of them are malignant. The others, in retrospect, could have been treated with EMR, but that's the trade-off you would accept?
I would accept it only if I would be able to really judge from before the removal of the lesion to correctly judge the final histology. And we are saying that we are not. Still, we are not. The other fact, honestly, we should talk about training. And we know that the rectum is our gym to learn how to perform ESD. So even in that case, no, some lesion could be resected by ESD. According to me, all the rectal lesions should be resected by ESD, but also talking about the training is an important point.
I would like to stress that rectum is not so easy, especially distal rectum.
So, ESD is not easy.
Yes, ESD is not easy, so training in the stomach, in the atrium would be probably much better. Well, we could go on forever. We don't have much time left. I think the conclusion is we have some guidance, but there's still the gray zone, which I think it's huge. You may be thinking it's not so huge, but with regards to studies, what do we need? We have 1 minute, so maybe 30 seconds?
30 seconds. Well, of course, you would ideally like randomized trials, right? That's what we all, as scientists, like to understand. But they're extremely challenging, aren't they? Because there's so many different indications and patients and optical diagnosis and variation in practice and in experience. So, but yes, ideally, I would like at least one, but ideally more randomized controlled trials to know.
Okay, so we don't have any, but to conclude, there's light at the end of the tunnel. There's another Dutch trial in the rectum where patient inclusion has ended, Matilda trial. And please watch us also during a Champions Den on Saturday, because there's a randomized controlled trial from Spain reported. So maybe when we sit here in, I don't know, 2 years, 5 years, whenever, we can discuss a little bit more on the basis of evidence. It was a great pleasure. Thank you very much.
Same.
And thank you for watching. And I hope you have finished your coffee and enjoy the further program.